So we're just going to quickly run through some of the equipment that you will use in managing this patient. First off, we have our drug kit. Pain relief obviously is quite important. In the ACT we have morphine, ketamine, fentanyl and methoxyflurane. If RSI is required or the patient deteriorates, succinylcholine is our paralysing agent, with ketamine as the pain relief of choice there. We also have our cannulation gear which would be needed. From there we have our main kit. The drug box actually in fact sits just in here. In here we have our shears, which is important to expose the patient to conduct a thorough assessment, a pupil torch obviously to check the pupils. In here we also have fluids which may be required, and maintenance of fluids is important, especially prolonged transport times. We have a manual BP cuff and SpO2 monitor, which is also good. We have an easy IO if we can't get IV access or if we deem it appropriate to use an IO. We have a small trauma kit there with just our basic triangular bandages, crepe bandages and gauze. We've got a sharps container on the left side, and we have a manual suction on our right that is just pump activated, so if we can't get oxygen or we run out of oxygen given the presentation. From there we've also got our cervical spinal collars, as most services do, stethoscope, which most people should have. We have our pelvic splint as well. Should have a low threshold for using this device, or as some services use, just blankets or sheets wrapped around. Very important to stabilise the pelvis in these patients if there is any inkling of fracture, given the amount that can bleed out before there are any recognisable symptoms. You don't want to be halfway to hospital when that goes wrong. We also have our Ferno track, important for comfort and splinting of the femur fracture, and our Kendrick extraction device. While this is an extraction device, it can also be used to spinally immobilise the paediatric patient. Sometimes, and quite often forgotten by myself and others, I'm quite sure, we've got our space blanket and standard blankets. I've put these in there simply because we're going to be exposing the patient, and it's really important in the trauma patient that we keep their temperature up. As we know, coagulopathy increases the colder they get, and it's much easier to keep someone warm than to try and warm them up. From here we'll just have a look at our secondary survey. Cheers. So now that we've gone through the equipment and we've had a look at some of the considerations of assessing this patient, this is the secondary assessment. You're going to start at the head, and you're looking for any body masses, any bleeding, any hematomas, and of course any blood, and then checking the facial structure, so the orbits, the maxilla, the mandible, if there's any deformities there. From there, you're going to use a pupil torch, just making sure each pupil is equal and reactive to light. Looking in his airway, you're going to see if he's missing any teeth, if there's any blood or he has dentures. And if it seems all clear, ask him to clench his jaw and see if he's able to do that pain-free. You're going to look in the ears for any CCF or bleeding, signs of a basal skull fracture. From there we move to our cervical spine, and you go behind the patient. We don't lift the head, and we're just going to feel, gently palpate down the cervical spine for any deformities or if there is any bleeding or hemorrhage. You're also going to check that the trachea is in fact midline, and there's no deformity in that, so it's not depressed if he's, for example, hitting the steering wheel. It's very important to consider the mechanism of injury. If the trachea isn't midline, it could be indication that he's possibly got a pneumothorax that's tensioning. We're going to check the clavicles, make sure there's no deformities there, and then the thoracic region. Gentle firm pressure under the axilla, under the breast, above, and down the sternum. From there we'll ask him to take a deep breath in and make sure he's actually in fact able to do that pain-free, or if there is pain. Doing thoracic assessment, We're then going to listen to the chest quickly and make sure that we have equal air entry on the left and right. Start at the apex and then move to the axilla. After that, we're going to go to the abdomen. We apply gentle rolling pressure left to right, top to bottom, and we're just feeling for any rigidity. Is he guarding at all? Is there a pain response to egress, or is there any distension? We'll check the pelvis by applying a firm pressure bilaterally. We don't want to lift the pelvis, especially if there is a lumbar or sacral spinal injury. Given that it's the pelvis is circular, obviously, it'll fracture in 2 points, and a dislocation at the cartilaginous joint in the centre is quite common. Have a low threshold for applying the pelvic splint in these patients, especially if they're unconscious, considering the amount of bleeding that can occur. Then we're going to check the arms. Both arms are the same, feeling for any pain, deformity. Is there any hemorrhage, abrasions or grazes? On the long bones, try and apply shear force, so that's the force top and bottom of the bone, just to make sure they're stable. Only do that if you don't think it is fractured, obviously, and there's no pain in there. Then we're going to check, you do that both sides, and then you're going to check neurovascular options. You'll start by grip strength, make sure it's equal on both sides. You'll ask him if he's able to raise his wrist and drop his wrist, and then if it's appropriate, articulate at both the elbow and the shoulder, and make sure that's equal both sides. Then check for any altered sensation. First, running up from the pinky under the axilla, and then along the outside to the thumb, and make sure this feeling is equal on both sides. The legs are very similar to the arms, making sure we're finding any deformities, hemorrhages, and applying that shear force where appropriate. Same with the lower leg and the tib fib. And then again, at the feet, we're going to check that we can articulate at our joints if it's appropriate. We're going to then do a neurovascular assessment again for his peripherals. I'm going to ask him to plantar flex against your hands, dorsiflex, and then if there's any altered sensation on the inside or then the outside, and make sure they're equal. You want to do it bilaterally, of course. So that's basically your secondary assessment. From here, when you roll the patient onto a spine board, and once you've got the collar on, you can do a thorough assessment of the back by stripping away his clothing. You'll palpate the spine, and you'll also auscultate the chest at that time. Okay, so the final part we're looking at is the final packaging and transport of this patient for a prolonged journey. We don't transport patient on a spinal board in the ACT, regardless of the time or distance. It used to be 20 minutes, but that's been removed, and we no longer transport on a spinal board regardless of that. We also don't have set head blocks, but we use rolled towels, as you can see I've done here, taped for the forehead and the chin. We have our collar on, obviously. As you see, we have a space blanket, and that's to regulate his temperature and make sure he stays warm. Let's remove that. Obviously, we're using the appropriate straps. We don't have any specific or proprietary straps to use to strap him to the bed, unlike the spinal board. But if you do, and you should try it sometime, if you do use these seat belts correctly and they're fast and tight and snugly, they do quite a good job. And it's very important that when you do stabilise the head, as we've done here, that you stabilise the rest of the torso, just to keep spinal alignment. You'll also notice we've got the pelvic splint on, that's been discussed. That doesn't come off, obviously, until he's been x-rayed and has been cleared of a pelvic fracture. IV access, should usually have, especially for prolonged transport, usually try for 2 lines. We have an IV here and an IO, obviously. You don't want to be overdoing the fluids, especially considering he has nowhere to go to the toilet. So you give fluid that is required, but try not to just let it run. When you are transporting, of course, make sure you're doing regular assessments, check for trends, and make sure that pain relief is adequate and the patient is comfortable. Lowering the patient's anxiety is one of the key things, again, considering that he's fixed looking at the roof the whole time, so constant communication is very important. I hope this was informative, guys. Cheers. Bye.